Students tend to neglect these topics, which is exactly why you need to know them well in order to get easy points on the exam. Today we're going to discuss sexual dysfunction, gender dysphoria, and paraphilic disorders. First, let's talk about sexual dysfunction. Now, in order for something to be considered a dysfunction, it must go on for at least 6 months and cause significant distress. Males and females experience sexual dysfunction slightly differently. So in males, the most common sexual dysfunction is erectile disorder. They can also experience premature ejaculation and hypoactive desire. Females, on the other hand, tend to have interest arousal disorders, and they also can experience genito-pelvic pain disorder, which is a fear of penetration and pain with penetration. Now, medical and hormonal causes of sexual dysfunction. It's important to keep these in the back of your head if the patient is experiencing sexual dysfunction. So vascular causes can occur. There can also be endocrine causes such as diabetes. There can be structural causes such as pelvic adhesions. Testosterone promotes libido, so if a patient has low testosterone, they might experience sexual dysfunction. On the other hand, if a patient has very high progesterone, they can also experience sexual dysfunction because progesterone inhibits libido. Now, medicine causes are very high yield, and this is because SSRIs are the most common cause of sexual dysfunctions as far as medication goes, so it's commonly tested. They can cause delayed orgasm and low libido. Other medicine causes can be antihypertensives such as beta blockers, antipsychotics such as risperidone that cause hyperprolactemia, and hyperprolactemia can decrease libido. There also can be anticholinergic causes of sexual dysfunction. So you need to keep all of these in the back of your head if you have a patient with sexual dysfunction. So how do we manage sexual dysfunctions? This can also come up on exams. So people can go through sex therapy, couples focus if they're in a relationship, and that can be beneficial, especially if the sexual dysfunction is psychological. They can also go through cognitive behavioral therapy, and if you ever see CBT on your exam as an answer choice, I would just click it because it's usually right. Then for genito-pelvic pain or penetration disorder, gradual desensitization, possibly with dilators, and then muscle relaxation techniques can be helpful for these patients. Now, for pharmacology that can help sexual dysfunction, you can probably guess that for erectile disorder, PDE5 inhibitors such as Viagra can help. Also, for premature ejaculation, and this is extremely high yield, SSRIs can be used to treat premature ejaculation because of their side effect of delayed orgasm. They can also use techniques such as the squeeze and stop-start technique. Next, we have gender dysphoria, and gender dysphoria is actually becoming more common on test questions, so it's important to be able to know how to recognize it and how to treat it. So in order to recognize gender dysphoria, it is someone who has distress accompanying incongruence between experienced gender and biological gender. You may see this person cross-dressing, wanting sex hormones, or having desire for sex reassignment. They have high comorbidity with major depression, anxiety disorders, and they are at elevated risk of suicide. So for the DSM criteria, there is a marked incongruence with the primary and secondary sex characteristics. There is a strong desire to be of the other gender or to be treated as such. And it must cause clinically significant distress or functional impairment. It can't just be a woman who wishes she was a guy, but doesn't really have any distress over that wish. For treatment, therapy is extremely important, and family involvement as well, especially if it is a youth experiencing gender dysphoria. If the patient is wanting gender surgical reassignment, it typically requires living at least 1 year in the desired gender role and then a year of continuous hormone therapy. Next, we're going to have paraphilic disorders, and paraphilic disorders are going to show up on your exam at least once, if not several times, so it's important to know them. For diagnosis, there must be a duration of at least 6 months of recurrent intense urges and fantasies. It must cause harm or significant distress or impairment in order for it to be an actual disorder. And there's various different types of paraphilic disorders. We'll start off with the no contact types. So voyeuristic disorder is arousal from observing unsuspecting nude and disrobing people. They are the creeps in the windows. Then there's exhibitionists, who are basically the opposite. They get arousal from exposing their genitals to unsuspecting people, so they're the flashers. Then we have the contacts and pain type of paraphilic disorders. So there's the pedophilic, who have the acts and urges with prepubescent children, 13 years or less. And then there's the voyeuristic, who have arousal from touching or rubbing against non-consenting people. Then there's sexual sadism, who get arousal from inflicting suffering on others, hence the sadistic part of it. And then there's sexual masochism, which are basically the opposite of sexual sadism. They get arousal from receiving humiliation and pain. Next, we have the object and identity type. So there's the fetishistic, who get arousal from non-living objects or non-genital body parts, such as the foot fetish. And then there's the transvestic. So they get arousal from cross-dressing. They are usually heterosexual males. And it's important to be able to distinguish between someone with a transvestic disorder and someone who has gender dysphoria, because both of them can cross-dress. But the difference is that people with gender dysphoria are cross-dressing because they want to be that other gender, whereas with transvestic disorder, they get sexual arousal from dressing as the opposite sex, and they may not necessarily want to be that other sex. So how do we treat paraphilias? You can actually use a combination of pharmacotherapy and psychotherapy. So the goal of pharmacotherapy is to decrease sex drive, and SSRIs actually are commonly a first-line choice because of the side effect of decreasing libido. Antiandrogens can also be used, as well as GnRH analogs, because they can suppress testosterone, which increases libido. Now, for psychotherapy, CBT is always the right answer, or almost always the right answer if it's on a test question. Social skills training, group therapy, and empathy training for victim impact. Now, we'll quickly go over what makes a better prognosis or worse prognosis. So for better prognosis, having only one paraphilia, self-referral for treatment, sense of guilt associated with behavior, and a later age of onset all are good prognosis. Now, for worse prognosis, it's the opposite, having multiple paraphilias, early age of onset, lack of remorse and denial, and referral by law enforcement after arrest, like they're not interested in getting help, is a bad prognosis. Questions on your exam. If you want more easy points, just click on the video on the right.